Hello, my name is Cameron Sabat, and this is Cutting to the Case. And today I'm joined by Dr. Oboh Weilke, and she is an associate professor of ophthalmology at Georgetown University School of Medicine and an attending physician at MedStar Georgetown University Hospital. She received her BA in biology with a minor in mathematics from Boston University, where her undergraduate research in neuroendocrinology led to her first publication. After earning her MD at Rutgers Robert Wood Johnson Medical School, she completed residency at SUNY Downstate and fellowship in cornea, refractive surgery, and external disease at the Wilmer Eye Institute at Johns Hopkins University. Before joining Georgetown in 2009, she practiced in Fargo, North Dakota, where she also served as Associate Medical Director of the North Dakota Eye Bank. Today, she divides her time between academic teaching, NIH-funded research, and private practice, focusing on corneal transplantation and cataract surgery. She served as the ophthalmology clerkship director for Georgetown medical students for about 15 years. She recently took on the position as the residency program director for GUH and WHC, and she continues to mentor residents in the clinic and operating room. She publishes widely on corneal disease, HIV-related eye conditions, and infectious keratitis. She was co-investigator on a multi-center study on herpes zoster of the cornea, funded by the National Eye Institute. Advocacy for her patients and her profession is very important, and she was the Washington, D.C. Metropolitan Ophthalmological Society president from 2021 to 2022. She's also the WDC MOS counselor to the AAO. She resides in Southern Maryland with her husband, two children, and her mother, maintaining close ties with her extended family. Thank you very much for joining us today.
Thank you very much for having me, Cameron. And thank you for that very flattering introduction.
Of course, it's too easy to have a flattering introduction for you. You've lived the duality of, this academic medicine and this private practice life that we discussed in this intro. I wanted to start out with what has each taught you about patient care, and how do you decide where you can have the most impact?
Mm, that's good. Um, each has actually taught me that patient care is the same and should be the same. Um, it's important to treat each patient with respect, never cut corners, and to always show empathy. That's very important to always show empathy to the patients. I decide where I can have the most impact based on the opportunity that presents itself. For example, some research projects or clinical trials, I believe, may be better conducted in an academic setting. Whereas some of my volunteer work, where I see patients free that are uninsured, are very easily organized in my private office setting.
Mhm. Yes. Yes. And really you see that duality kind of show up in those underinsured and the yes. And also I my second question was, you know, specifically women in medicine have had very different experiences across generations. And I wanted to know how you see the culture shifting for today's trainees and what aspects you still think might need to be changed.
Wow. I mean, first of all, I must say the culture is shifting, thankfully.
Hmm.
Thankfully. We are training more women in medical schools and in ophthalmology. So, with that comes more requests for certain amenities. I'll give you a good example. When I walk down the hallways for of our major conferences now, I would typically see rooms that were designated for women to be able to pump. This is something that is very different from a decade ago when I had my babies. My husband and I would typically choose a hotel that was closest to the convention center. So in between my breaks, I could go back to the hotel room to feed my baby and pump and then go back to the conference. I would have really loved the opportunity to have had more availability to be able to still engage in the conference and not have to keep running back and forth. So I think it's great that I see rooms that are designated for nursing moms. I think that's wonderful. There are still many aspects that have to change, though. I believe we still need women in leadership roles, both as chairs in ophthalmology departments, in departments, in academic departments, period, and even hospital-wide. And we do need more deans in medical schools that are female. I think the last quote I saw was it's about 17% of residences that have females as their chair person.
Hmm.
And that number is not that much different for medical schools. The dean's percentage of women hovers around 18%. So we still have a ways to go.
Yes. Yes, and lots of progress has been made and lots of progress to be made, really, in those respects. But I'm heartened to hear those advances in, breastfeeding and all those other accommodations that weren't seen before. And, I was also curious to ask you, a leader in the field, about ophthalmology as it sits at the intersection of medicine, surgery, and technology. This is one of those fields that's really poised to feel the shift in as new technology arrives onto the scene. Do you believe artificial intelligence will redefine the role of ophthalmologists or simply extend what they do?
Cameron, I really think it's a little of both. I really believe that. We already have some of that in certain private and primary care offices. They have cameras that are able to take pictures of the fundi when a patient is dilated.
Hmm.
These cameras oftentimes come with programs that are able to interpret the pictures to determine what the probability or likelihood of some of these findings representing diabetic retinopathy are. So we have the cameras, we have the program that interprets this result,
Hmm.
and that enables the primary care physician to refer the patients on to a retina specialist or an ophthalmologist, a comprehensive ophthalmologist, just for screening.
Hmm.
So places that are remote or don't have, or where patients don't have that easy accessibility to ophthalmologists, this screening tool has been able to provide invaluable information, and an ophthalmologist doesn't necessarily have to be the primary person doing the screening. But it's important data that an ophthalmologist can have, and this way we're able to see patients that do need to be seen.
Hmm.
So this tool, or AI in this sense, is also acting as an extension of what we would do as ophthalmologists.
And especially because a lot of these conditions, I mean, as they say, the eyes are a window to the whole body. And so, as an ophthalmologist, you are oftentimes at the forefront of diagnosing a lot of these major systemic illnesses as well, which is part of what makes this technological advance so important. It's incredible to see.
Absolutely, absolutely. And you raised a very important point. Yes, there are times that just by taking a look at the retina, we can diagnose high blood pressure, diabetes, different immune conditions, immunological conditions that are manifested in the eyes. The primary care doctor doesn't necessarily have to know what this fundus means, but by having a camera that can interpret this data and funnel the patient to the ophthalmologist, we're able to really partner nicely with the primary care doctor without even being on the ground for
Mhm.
the initial exam.
Which improves the range of services that you can provide geographically.
Exactly.
Yeah.
I think overall that helps to deliver better care. So,
And as you were discussing earlier about the duality of academic medicine and private practice, that you've been able to see all of these, inequities, and you've been able to shine light on them. I mean, even the fact that the nearest specialists to in the Native American reserves in America are 88 miles away. I mean, they aren't getting specialty care. So, a lot of the American population doesn't have access to a lot of specialty care. It's priced out of their range if they don't have insurance. And so, all these things come together to form these barriers to care that are slowly being eroded by technology. It's incredible to see.
it is. It is.
Yes, yes. So I now wanted to shift toward your training. So you trained at Wilmer, which is obviously one of the most prestigious programs in the world. What lessons from that environment still influence how you mentor residents here at Georgetown, which is similarly one of the top institutions?
Thank you for this question. I feel like I've been blessed and lucky to have trained in a place like Johns Hopkins, Wilmer Institute. I also feel very fortunate to be able to work and teach and train residents and medical students in an institution such as Georgetown University. As I said, I feel very blessed and privileged. So there are many things that come to mind about my training at Wilmer, but one that sticks out is the collaboration that was present in a center like that.
Hmm.
There were times that we had attendings when I was a fellow. We had attendings at Wilmer that were world renowned for a particular topic in retina or glaucoma, but they would send their patients to the cornea service for us lowly fellows to take a look at these patients if their pathology was in our area of expertise. And I always found that fascinating. And what I learned from that is that you're never too great to collaborate or learn from others. And I've really tried to follow that till now. I learned from my medical students, I learned from my residents, I learned from the other staff members we work with. I think if someone keeps that in mind, that you doesn't matter how famous or how good you are at what you do, you could always learn something from someone else. And they may not even be your equal, but you could learn from them.
That's incredible humility too, to understand that even in a hierarchical medical environment, there's still a two-way exchange of information.
Yeah,
That's
absolutely.
beautiful. And one of the reasons why we need diversity in medicine and women in leadership positions and all of these other elements that make a medical student robust. Yes, a medical environment. So I also wanted to kind of broaden the conversation to your research as well. So it spans a lot of things like HIV, and I want to be very respectful of your time as well. So I, this can be our final question, but your research spans HIV, infectious keratitis, and corneal disease. What questions remain unanswered in ophthalmology, and what are some exciting developments you see in the field looking forward, like xenografts or artificial grafts?
Oh, Cameron, there are so many questions that remain unanswered. But I think the beauty of being a scientist is being always curious about answering questions,
Mhm.
especially the ones that still remain unanswered, right? I think that's the beauty about being a scientist. So I will give an example, and since I'm a cornea specialist, corneal transplants, we started off decades ago doing replacing the whole cornea, all 5 layers. And then over time, we realized, hey, we could just replace the diseased part of the cornea. Then we do partial transplants like decimal stripping endothelial keratoplasties or DSECs, which is a procedure that can be done for a corneal disease or pathology known as Fuchs dystrophy, where the posterior part of the cornea is where the pathology lies. So then we shifted to culturing some cells that we can deliver into the eye to see if they can help with the area of diseased cells. So I think that we've done a big shift from actually doing transplants through surgery to a point where maybe all we need are cells. We just need to culture the cells and see if they can help repopulate
Mhm.
the part of the diseased cornea. This has so many advantages. It would help decrease the demand for tissue, and it will help deliver treatment to more people that are needed, as opposed to just using a transplanted tissue or organ donation.
Mhm.
I mean, we also have great advances for using devices that that are synthetic for keratoprosthesis, for example, is a device that is used to replace the cornea if someone has had many immunological rejections with donor tissue. So there's still a lot we can do with that to make sure these are well tolerated in the eye, to make sure they last longer. There's constant research that we can still be done. Number one, to maybe even decrease the amount of surgeries we're doing
Mhm.
by culturing cells, or to even make the surgeries a lot safer and the devices a lot more tolerable in the eyes. Um,
Yes, yes.
yeah,
And those transplants are incredible. I've been fortunate to be part of that research in the vision graft for gamma irradiated corneal tissue for therapeutic penetrating keratoplasties. So it's a very
absolutely.
exciting frontier.
It really is. Cameron, I must say I'm having such a fun time with you. If you had one more question for me, I would be open to that.
Okay. Yes, absolutely. I would be honored. So, if you had to distill your philosophy of leadership in one or two sentences for the next generation of doctors, what would it be? The entire audience is listening.
Oh, wow. Cameron, that's a very good question. A very good question. I think in order to lead well, one must be willing to listen. You have to be able to care about those who you are leading, and you have to actually show them that you care. I go back to empathy, but it's very important to show empathy. And if someone that you're leading makes a mistake and you have to correct them, I think you should let them know that you've probably done worse and that you turned out just fine, and so will they.
It's
And I
incredible.
think that's my philosophy.
Yes, yes. I can see you lead with a spirit of humility and kindness. And also empathy, that people tend to be very hard on themselves and to kind of lead with that human element of I've been there too, and we can walk through this together. It's
Yeah,
really an inspiring approach.
absolutely.
Yes, thank you very much. And yes, so this has been Cutting to the Case with Cameron Sabat. And until next time,
Thank you, Cameron. It was really a pleasure.
thank you. Thank you.
Take care.
Bye bye.